therapeutic. PTK. PTK is divided into plain PTK or customized PTK. Plain PTK is either dry PTK or wet PTK, and then there is thick wet PTK and light wet PTK, but this is not the issue for today. Today we are discussing customized PTK. Are we going to go for wavefront guided or topography guided PTK? Now, what's the difference between customized and plain PTK? If you have plain PTK, the energy is equal everywhere. Do you have a projector here? Projector? Pointer? If you have plain PTK, the energy will be distributed equally all the way, and every part of the cornea will receive the same energy like the other. So all what we get from plain PTK is replication of the surface. The surface itself is taken down and down and down exactly in the same shape. But if you go for customized PTK, the energy is divided, higher energy to the place where you want to give, and much less energy to the place where you don't want to give. And this means that you can remove tissues without affecting the other tissue, and you proceed until you get a plain surface. So this is essentially the difference between plain PTK and customized PTK. It's very important before you think of customized PTK, registration. Registration of what? Registration of the shape, location, and magnitude of the aberration, as well as if there is any cyclorotation. This is all the patients, they have cyclorotation. So you have to detect this cyclorotation and compensate it. So if you don't have this correction, detection and compensation, forget about customization. Also, the treatment should be over the visual axis, not somewhere else. So these are the main 3 points before you start customization. And we can see here that if the eye is being rotated and the energy is not going to the place needed, first of all, you are not going to correct the error. Secondly, which is more important, that you are going to induce a high order aberration. So you are going to make it even worse. Now, are we going to treat the function or the shape of the cornea? If you are going to treat the function, you go for wave front, and we will talk about it. If you are going to talk the shape, you are not happy with the shape, you go for topography guided. Okay, so this is, and topography guided, we don't say wave front topography guided. We say topography guided customization. But wave front, whenever you use wave, it means that the whole eye, the whole ocular or total or whatever you call it, but it is the whole eye. So the function is the whole eye. What's the difference? You may have an error on the corneal surface, an aberration, but this aberration is being corrected by another error inside. So function-wise, this error has no problem. So you don't correct it if you are using the function treatment. But if you are using the shape, you are going to correct the anterior one, and you are left with another one, so there is another one. Okay? Now, the function like that, look at all the lamps look like together, but one of them is only functioning. So you know the shape is almost the same. But if you look at the shape, this is the shape what you see in the topography. They are all different shapes. If you are using the function, it is wavefront guided. And you have to know that wavefront, because it has to go through all the eye, so it is guided by the pupil. If you have pupil slightly decentered, so your treatment or even your notification is decentered, because you are through the pupil. If this door you want to go, but the door is, if this gate wall, but the door is there, you have to go from there, not from the center. So this is the problem with wavefront. It has to go through the opening, through the pupil. But it does not correct everything. It takes the whole wavefront. So it is tissue saver. It helps you to save your tissue. On the contrary, the shape one, which is topography guided, it is for on the visual axis, because this is when you take that photo, you ask your patient, thank you. You ask your patient, look at the light, and you took the topography on this visual axis. So when the machine will correct on the topography guided treatment, it goes on the visual axis and you correct on the visual axis. But this is tissue hunger. It eats a lot of tissue. So it has some benefit that it is on the visual axis, but it eats too much tissue and it does not correct everything. The other one correct most of the things. A tissue saver, but through the pupil. You have to put yourself in between. Now, so these are two gentlemen. One is the total, one is the corneal. They are fighting. Who's better, red or blue? Now look here. This is the shape of the cornea before. If you see a nice photo after, so it is corneal topography. If you see a picture that is not really that much changed, it is ocular. But look at the tissue. This is too much tissue, and this one much less tissue. Okay? Again, this one and the visual axis. This is the visual axis. So the corneal topography or topography guided here on the center, because this is where you take the picture. While the ocular, because it is related to the pupil, it is on the center of the pupil. And if the angle kappa is high, you are shooting the wrong person instead of your friend. So again, look at the picture. This one is better photo post. So this is corneal, this is worse. So this is ocular. But look at the ocular, limited to the pupil. Look at the corneal. It is not limited to the pupil. It is shifted. The treatment in the center of the visual axis in the center. Here the visual axis is not in the center. Again, this picture, beautiful, and it is not good, but look at the function. So, and this is the angle kappa. You see, sometimes it is so huge that you have to be sure about it. Now, this is really not major problem. Why is that? Because most of our machines now, you can decenter your treatment. So, you can shift your treatment from where it is, I mean in the wavefront, not in topography, because topography is already on the visual axis. But if it's wavefront, you can ask him, please shift it to the visual axis. And here it is where you can shift it. So the benefit of wavefront, of topography guided, being on the visual axis, is no more benefit, because you can get the same with the wavefront. So most of the machine, you have to look at your machine before you go for wavefront guided. Shift it to the center of treatment or pupillary axis. Now, these are fighting together, but we have to say, sorry, gentlemen, you are both wrong, and we are not happy with your results. You are looking to the tip of the mountain. You forgot what is inside, and all your treatment is not enough. This is because you are looking here, and you are not looking to the stroma. There is something called epithelium. Epithelium is trying to correct the problems, and all our pictures are on the epithelium, not on the stroma. Stroma is absolutely different. If you look at this picture, this is the same patient. This is before you remove the epithelium. This is after you remove the epithelium. Now imagine, look at the K readings. It's 46 here. Is it? I have to have my other glasses. Anyway, if you look at the K readings, it's absolutely different. Yes, it is 45 with the epithelium. It is 47. This is the reality. So it is really very convex. And then look at the astigmatism. It is 0.4. Very good. Just 0.5 degree. But if you remove the epithelium, you discover it is 4.5. So the epithelium is covering a lot of abnormalities in the stroma. And if you consider treating the epithelium, you are not treating the stroma. You have to take this in mind. So either you remove the epithelium, this is the epithelium masking. Another point, that whenever you treat, the ablation rate of treatment to the stroma is not exactly like the ablation rate on the epithelium. So they don't go together simultaneously with the wave. One is moved more than the other. And that's why the results are not good. Now, as we said, the shape and function, but we have to know something, that mostly shape and function and mixed. If you look at keratoconus, you look at the shape, you look at the function, they are both mixed, and so you can use both systems. And now look at this one here. This is high spherical aberration. High spherical aberration alone, you are looking only for high spherical aberration. It's a wavefront anomaly. Now, if you go for topography guided, the shape is perfect. Look at this. The shape is perfect, but there is no really gross change. If you look for wavefront guided, the shape is not that good. But look at the difference. It really reduces the spherical aberration. The patient is happy here. You are happy here on topography. He is happy here on function. The same. The function is the same. Look at the energy here and look down here. This is beautiful here. This is as if it has not changed, but the picture is different. So the wavefront is really correcting the abnormality. And then you look at this one. This is a keratoconus, and you only treated one thing. No sphere, no cylinder. We did nothing here. It is only the wavefront. By wavefront, you change it from irregular to regular astigmatism. And changing to regular astigmatism, this really gives the patient a lot of improvement in vision with glasses or with contact lenses or with phakic IOLs. Now, in decentered ablation, both shapes and function are bad. So you can use both modalities. You can see shape are almost the same, and the tissue eating is not that different. So you can use both in decentered ablation. And again, look this one here and that one here. This is ocular guided. This is topography guided, but the same, not gross function. So in keratoconus, not gross function. Now, these are other different cases. You can see how you can change it only by topography, only by wavefront treatment. You are not treating the shape, you are not treating sphere, you are not treating cylinder, only wavefront treatment. And look at the shapes. They look really beautiful and nice. And we have another discussion, another meeting, how to do these steps. Thank you very much.
Thank you, Dr. Sami. You have got one more post-PRK
Yes.
LASIK. Post-LASIK PRK.
I hope they excuse me for that. 2 lectures, one after the other. So sorry for that. Anyway. Are you ready? Bioptic. All of us know bioptic. What is bioptic? We do bioptic. If you remember the old days when we have the ACIOL to correct high myopia, and that time we did not have toric ACIOL. We just, patient is minus say 14 with minus 3 cylinders. So we used to make a cut for a flap, and then we put lens, which is minus 16 or whatever, and then whatever residual of astigmatism, we open the flap and correct it. This is bioptic. Bioptic is to treat on 2 steps. Okay? And in this technique, also on 2 steps to treat. And using the bioptic is to evaluate the refractive surgery outcome of patients who have relatively insufficient corneal tissue to a given error. Somebody who is given error something like 7, but his cornea is only 500. The 7, if this patient has cornea 550, you could do it. But if he has 500 alone, this is a problem. On the contrary, if a patient has 4 diopters, but his cornea is only 460, so maybe not enough. So bioptic, if either the given treatment needed is higher than the tissue available. So this is to treat patient with either relatively thinner cornea than needed or higher refractive error than given stromal thickness. If you have such patient, if I give you a patient like that, you will consider 1, 2, 3, 4 things, and I'll give you the 5th option. First option, that you full corrected. But because you are afraid, so you instead of giving him 9 diopter treatment zone, you will go for something like 5 diopter treatment zone, so it is less depth. This is a good idea, but you will increase the incidence of spherical aberration, and the patient will be happy at night, will not be able to drive will be happy at daytime, and will not be driving at night because of the raised spherical aberration. You'll say, okay, no need. So I'm going to treat him fully with full treatment, the 9 millimeters. Okay, very good. He'll be happy. But the residual corneal stroma is minimum. And this patient, he may have ectasia later. So you'll say, why to do both? Let us go for PRK. Good idea again. But there may be incidence of haze. Haze is high, especially if you may not correct, especially if you have high cylinders. So you may consider phakic IOL, but you have to look at the endothelial cell count, the AC depth should be a certain limit, the white to white, and so on. These IOP, all measurements, you have to take it before you consider phakic IOL. Or I may add the bioptic technique, which is just partial correction. If he's minus 10, tell him, I'm going to correct. Whatever you have tissue is enough for 6. So you give him just partial correction of whatever you give him without jeopardizing any safety or quality. You don't want to go smaller for bad quality. You don't want to go big for the safety. You don't jeopardize this, but you give him whatever you can, 5.5 or 6 or 7.5. This is on the first stage. And you tell him, 6 months later, sir, we are going to do the second stage. And the second stage will be on the flap and will be PRK. So you are not at all touching the stroma. You are not at all affecting the safety and morbidity of this eye. Now, let us look. So the first step is femtosecond LASIK treatment to the cornea as much as possible. Second stage on the flap. On the second stage, what we do, not only correcting residual refractive error, but also the induced high order aberration. All of us, we know that whenever we do LASIK, we induce high order aberration. And this high order aberration get more and more and more with the higher degree of refractive error. So what about if I can bring it down also the high order as long as I have something in my hand? And this is the bioptic. Now, we had here, all cases had topography, tomography, spherical aberration, Q value, bachymetry, refraction. They were all within normal value. And all these were repeated after the first and second treatment. We used 9 Quest EC 5000 and femtosecond, it was Zimmer LDV. Now, if you look at the total refractive error, starting from, say, -9, and then in the first group, second group, 2 to 4, 4 to 6, 6 to 8, more than 8. More than 8 is group 5. So if you look at group 5 here, this one, they all end up with residual myopia, as we know. But the group 5 ended with the higher because by intention we don't want to correct everything. Now this one is the bioptic, and this will be the beginning point here. Look at the end. So I started with this one and end up with that one. So I ended up exactly as I'm treating -2. Now, look at the Q value at the 4. All of us, we know that Q value is in minus. It's about -2, -2.5, or 2.7, something like that. And Q value, what does that mean? Q value, the cornea, it's not rotated. The cornea, whenever you go at the periphery, it just gets flatter and flatter and flatter. And the change in the sphericity, this is the sphericity. If the cornea is rounded, Q value is 0. But if it is inside, Q value is positive Q value. It is outside, so it's negative Q value. So we know, all of us, the cornea has Q value of negativity. This is normal. And the idea of negativity is to push the light all to meet at the retina instead of having different positions. So can you hear me? I thought my voice. So the idea is to push the light from the center to the retina, from the periphery. Also, if it is flatter, it goes to the center. So this is the idea that God makes our cornea like that, so the light goes down. Whenever you do myopic correction, you flatten the center and you make shoulder for the periphery. So your Q value either been reduced from the minus or even get plus, which means that the light goes up again. Is that clear? So spherical aberration become more positive. No. And this is all before. All before is in the minus. And we know that it goes higher and higher. Up to 0.5 is acceptable. But here, look at it. 0.8 in higher degrees. 0.8 plus 0.8, really the patient will hate you. They cannot drive at night. Now, this is after the treatment. Look at this. It goes back to here. So it goes back to +2. Patient will be happy to drive at night. Okay? So you corrected one of your mistakes. Now here, the Q value at 7 millimeter. You have to take Q value at 4.5 millimeters, at 7 millimeters. The Q value, look here, it goes after this, it goes higher, 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 and then you shoot it down. So the Q value is getting down. High order aberration. We know, all of us, we are inducing high order aberration. And higher order aberration is getting higher, higher, higher. And the second treatment, or in the last, it goes even better than the first. So you are not only correcting residual refractive error, you are correcting quality of vision as well. Now, total positive spherical aberration. What is positive? You remember we said positive spherical aberration. If all the light goes to the retina, it is 0. But if it goes in front of the retina, it is positive spherical aberration. And all the myopic treatment, it causes the Q value to become like a knee. And this will bring it to the plus. So we will say increased positivity of spherical aberration. We need that sometimes, but we need to reduce it down. The more you reduce it to the surface, the better the quality, especially at night. And that's why here, the spherical aberration, it goes higher and higher and higher. And then with the second step, shoot even better than the first. Now, look at this. Simple, nothing. Okay, but look at the numbers. Here, 43. Here, 35. Difference in value, it's about 8 diopters. 8 diopters in K value. 8 diopters in K value means 1.2, يعني about 9.6 diopters of myopia. So you have corrected 9.6 diopter of myopia by just reading the K value. Now you expect that patient cannot drive at night. But look here, the Q value, it was minus 13, minus 18, minus 22, plus 32. He can drive at night, he's happy. You corrected 10 degrees with very good quality, not just correction of the amount, very good quality. Again, look at this one. First, second, this is before. He was 41, reduced to 35, so this is 6 diopters here. And then here, 44, so there is another 1 diopter. So from 41 to 44, 7 diopters on K, which means about 8 diopters on refraction. So you corrected 8 diopters on refraction. Excellent treatment zone, excellent treatment zone. Now look at the Q value. Q value was excellent because this is normal patient, 0, minus and minus as we said. Look here, this is a disaster here. Plus 88.88, 1.2. It is really a disaster for the patient. Now, in the third treatment, he's happy again because you shifted him here. So yeah, the Q value is being improved beautifully here. Now this is the spherical aberration. Spherical aberration was 1.02 plus طبعا, huh? We said all plus. 1.2 becoming 2.15, raised more, and then back again to 0.008. So it is almost touching the 0 line. So there is no spherical aberration at all. Look here, number 12. Spherical aberration getting higher, and now here, look at the difference. So really, the bioptic technique, it gives you another chance to correct whatever residual there without jeopardizing the quality or safety, and then correct any problem you induce to that patient. Thank you very much.
Dr. Sami,
Yes.
how will you pronunciate this?
Zainab. Sharif?
Yes.
Miguel. Miguel Ritchie.
Dr. Miguel Ritchie, is he here? So next is me.
Sharif?
Yeah. Alan or Silent. बिस्मिल्लाहिर्रहमानिर्रहीम ले आए भाई उसके ऊपर Now I have shortened my presentation. This is not the presentation. I am just presenting my two case reports so that we can fit into the time. And the purpose of presenting these excuse me, जरा ये बता दें भाई एक ये है ठीक है और अच्छा ये है ठीक है okay. So the purpose is to highlight the importance of minor problems. So whatever surgery we are doing, cataract or LASIK, or we have to take into consideration every step, and we have to take it very seriously. आप मुस्कुरा क्यों रहे हैं भाई? So we have to take it very seriously, whether we are doing corneal section, we are doing capsulorhexis, we are implanting the lens, centering it. Every step has to be taken very seriously because these minor problems become major for patient post-operatively. And the second purpose is can never think that whatever patient is saying is not true. Take it very seriously before writing him off as a psychic patient. So the purpose is this. So these are the cases. Now this is a 60-year-old patient who underwent multifocal IOL and he complained of a severe glare at night. And the glare was so much that he said when truck comes and it is just a meter away, at that time he saw that this is the truck. And he was about to die. And the glare, he couldn't explain the glare. And when I saw him, his vision, as you see, 6x6, his refraction, you can see, is well under, doesn't explain anything about the glare. And this is his epithelial mapping, almost normal, both eyes. This is his theoretical vision on eye trace, normal. And as far as centration, because this is a multifocal, trifocal lens, so we will thinking that it's a decentered lens and that is causing glare. You can see it's a beautifully placed lens, and you can see the angle kappa and pupillary center, angle alpha almost in the center. So it's not the cause of the glare. Though the higher order aberrations are well controlled. So what's the problem? So we did the retinal spot diagram. This is the reference of the spot diagram. This is how a normal spot diagram looks. And in this patient, you can see we didn't find anything on Zernike's this thing. And we have to be aware, or we should keep in mind, that not every light dispersion can be picked up by Zernike's model. So this is one of them. And you can see here that when light falls here, something is obstructing here and the light gets dispersed. And this is so much dispersion that he couldn't see the truck that is coming on. So what is the problem? So we examined it carefully, And we came to the, this is another map of opacity map, and this shows there is some opacity, and this is the contracted rexus seeing here. This is a very minor, we never considered this and never give any importance to this. But this minor rexus is producing so much glare that he couldn't cross the road. So what I did, that I YAG lasered this. First, I thought I should go in and cut it, and then I tried with the YAG laser and removed that piece of rexus. And you can see the dispersion that was occurring here has gone down. Patient was very happy, and this is about a year back, and he's very happy still, and he's doing. So the purpose here again, that never think that this is a psychic. We, most of the time, we consider the patient as psychic, and we keep on writing antipsychotic drugs. So there is no point, and take it very seriously, examine him, order all the investigation, and you will find something. So this is my first case. The second case is this one, a 42-year-old female, a school teacher, underwent bilateral cataract extraction. We implanted a multifocal, trifocal lens, and after a week, she started complaining of severe photophobia and burning. And the symptoms were more severe upon waking in the morning. This is the most important thing. The symptoms were very severe upon waking in the morning and subsided during the daytime. So we did in the right eye, we did the Placido images, took the Placido, and you can see that there is a tear film is disturbed here. Again, the second picture again at the same place. Third picture again at the same place, in the right eye. So we did the dry eye analyzer, and you can see the BUT here, and on the same place as almost on the same place as the tear film is disturbed. And left eye also, you can see here the disturbance in the tear film. So, and again in the left eye also, you see the breakup time here in the same area. So the problem is not with the tear film problem or dry eye problem. The problem is something with the cornea. So we took the B scan of the cornea, and this is the normal B scan of the cornea. This is the stroma. This is epithelium, and the black one is the tear film. So this is tear film. This is cornea. This is epithelium. This is your stroma, and the black thing is your Bowman membrane. Here, this is the Bowman membrane, and this is stroma, and this is your epithelium. The white is tear film. So this is just a reference of a normal person. So on the anterior segment OCT of the right eye, in the central cornea, you can see that the stroma is here, epithelium you can see here, but you can see the Bowman membrane broken, and it's all broken, and again here also you can see the broken Bowman membrane. In the inferior part, you can see a clump of Bowman membrane, no Bowman membrane here, and there's a clump. Here also, you can see the clumping of the Bowman membrane. In the left eye also, you can see similar picture. And the Bowman membrane is absent here. You can see here, but not here. So, and here in this picture also, you can see the broken Bowman membrane. So we diagnosed this as a recurrent erosion syndrome, secondary to Bowman membrane dystrophy, membrane layer dystrophy, and we placed him on we placed her on contact lens for 5 days, and started the preservative-free hyaluronate drops 2 hourly and preservative-free 0.3% sodium hyaluronate gel nightly. And I think it's almost 6 months now. And last I saw her 4 months back, she's still on the same treatment, and she's very happy. So the purpose, again, highlighting, don't take patient lightly, take them very seriously, and whatever they say, think in terms of that there is something wrong in the eye and look for it. Thank you very much. Sharmeen Akram, PTK platform for refractive PRK. Sharmeen Akram is a consultant ophthalmologist in Aga Khan University Hospital, Karachi, and she's a very expert refractive surgeon, and I envy her.
Thank you so much, Dr. Hashwani, for such a wonderful introduction. Let me say it's the other way around. I was looking at the retinal spot thing that you had shown, and I was just saying all the things that you have in your center, hats off to you. And I have a similar case also, which I'll discuss maybe in another meeting, the one that you had discussed about panoptic lens and then having this kind of a contraction. So I've done YAG laser. Let's see how the patient does now. First of all, thank you for providing me this platform to give my presentation. And this is on PTK platform for PRK, which many of us are doing. It's just a more detailed than what we do at our center. That's my declaration slide. And so photorefractive keratectomy, most of us who are over here are probably doing refractive surgery, and they're aware that PRK is one of the laser-based techniques of surface ablation to correct the refractive errors. Now, conventional PRK, we know, removes the epithelium by various modalities, which include with scrapping with the laser or with the blade, or it can also do using alcohol-assisted blade to remove the epithelium. It is different from LASIK because now the whole epithelium is being removed. Once the epithelium is being removed, the PRK never got so popular as LASIK because there is the issue of epithelial healing, the corneal haze, the time required for an optimal refractive outcome, and also the post-operative pain. Keeping these in mind, then there was the introduction of transepithelial PRK, and in transepithelial PRK, the laser were used to remove the epithelium, and the same laser was then used to do a refractive ablation. And this was based on the fact that if we are able to improve the reepithelialization, then the corneal haze will be less, the refractive outcomes will be better, and also the post-operative pain will be better. Keeping this in mind, two kind of transepithelial PRKs were introduced, the two-step and the single-step. And in this, the difference is that in the two-step laser, what we were using was, first we used a platform, which is the PTK platform, okay? And that is used to remove the epithelium. Following this, then the laser charges again for the refractive platform, which could be wavefront optimized. In the single step, which some of you might be familiar with, is also called the Streamlight with the Excimer X500. So what happens in that is that you use the same laser, but now we are not using the PTK platform as such. There is an inbuilt platform of the PTK with PRK. So the laser doesn't stop in between and it continues the treatment. So there was a comparison done, and this study was published in 2022, and in the single-step and two-step PRK, and the study did show that there is a shorter healing time with less post-operative pain, And also better refractive outcome means quicker refractive outcome, but no effect on the post-op haze. Now, the disadvantage of the single-step PRK is it's more costly, it's not available everywhere, and there is no Contora. Those who are familiar with this platform can understand that it's not available with single-step PRK. And the only thing that they found was that the post-operative pain was less compared to the traditional PRK. Now, the disadvantage of the two-step trans-PRK was that there was an undercorrection. So the two-step was less costly than the single step, but there was an undercorrection. There was a myopic shift, and if that is not corrected, then your patient will end up with a 0.5 or a 0.75 myopic shift. So how was that happening? So for that, we have to understand is the PTK platform. Okay, so we are using the PTK platform to remove the epithelium. Remember that the classic PTK platform is inbuilt to remove the 50 microns, but the cornea is not even in its thickness. So it is thicker towards the epithelium, tends to be thicker towards the periphery than toward the center. So there is what our first speaker mentioned, there is an epithelial masking there, okay? So there tends to be a myopic shift of about 0.25 to 0.5 and can go up to almost 0.75. This is what was corrected in the single step. But if we are able to correct that in our refractive ablation, then we are able to get a very good post-operative refractive result. And this was also shown in a study which was carried out and published in 2021. Then there was also comparison between the transepithelial PRKs and the conventional PRK. And one study by Hassan had reported that there was faster healing with the conventional as compared to the transepithelial PRK.